Hello, my name is Octavia Bane. I am a postdoctoral researcher at the Translational and Molecular Imaging Institute in Mount Sinai Hospital. I will be presenting an overview of my scientific paper, Hemodynamic Measurements with an Abdominal 40-Flow MRI Sequence with Spiral Sampling and Compressed Sensing in Patients with Chronic Liver Disease. This paper has been recently published in the Journal of Magnetic Resonance Imaging, or JMRI, and this prospective study has been funded by 2 NIDDK grants. Phase contrast pulse sequences with 3D vessel coverage and 3-direction velocity encoding, or 40-flow, have been validated against 2D phase contrast and Doppler ultrasound for measurement of blood flow in abdominal vasculature. 40-flow Cartesian sequences, however, have acquisition times on the order of 10 to 20 minutes because often they require respiratory gating. This has precluded their widespread clinical adoption. Our paper proposes a novel sequence using spiral sampling combined with compressed sensing, which achieves acquisition times of 20 seconds, enough for one breath hold to cover the entire abdominal vasculature. Here we have an example showing the streamlines from spiral 40-flow data in a patient with cirrhosis. And we can clearly see the portal vein, the enlarged splenic vein, and the gastroesophageal varices. The purpose of our study was to determine interobserver reproducibility for flow quantification parameters in abdominal vessels using a single breath hold validated spiral 40-flow sequence. We also determined test-retest repeatability and correlated the flow parameters with cirrhosis status, MELD scores, child puke scores, and an imaging-based portal hypertension composite score. This was a prospective single-center study which enrolled patients with chronic liver disease and clinical indication of abdominal MRI. The patients had the option to consent to an additional 40-flow acquisition at the end of their clinical exam. The exams were performed at 1.5 Tesla in fasting conditions. 2 patients were excluded due to poor image quality, and in the end 52 patients had successful 40-flow imaging. 25 of these patients had cirrhosis. 4 patients also had test-retest 40-flow without moving or repositioning the patients. The phase contrast acquisition consisted of a stack of spirals with velocity encoding and velocity compensation. 4 stacks of spirals were acquired in each cardiac phase. For the technical details of the acquisition, you can consult a publication from our group. The orientation of the acquisition was coronal, and we used a velocity encoding parameter of 60 centimeters per second. The acquired voxel size was 2.5 millimeters isotropic, and we had an equivalent acceleration factor of 6 compared to conventional 40-flow acquisition. A prototype software was used for data analysis. A single observer segmented up to 13 abdominal vessels in the entire patient cohort. Interobserver evaluation was performed by a second observer in 15 patients. Regions of interest were placed on the vessel segmentations as shown in the example here, and vessel cross-sectional area, through plane time average and peak velocity, and through plane time average flow were measured in the regions of interest. The clinical parameters collected were liver fibrosis stage, which was determined from liver biopsy, or from MRI and MR elastography in the absence of biopsy. We also computed MELD and child puke scores and a composite portal hypertension, or pH score, based on MRI. The composite imaging score is an additive score that evaluates the severity of ascites, the diameter of the spleen, and the number of varices. A previous publication from our group correlated this imaging score with invasive measurement of the hepatic venous pressure gradient, or HVPG. Thus, a cutoff score of 3 corresponded to portal hypertension, whereas a cutoff score of 4 corresponded to clinically significant portal hypertension. Interobserver and test-retest repeatability were evaluated through Cohen's kappa for agreement of vessel segmentation between different acquisitions. The quantitative parameters were evaluated by the coefficient of variation and by Bland-Allman statistics. We used Mann-Whitney tests for group comparison according to cirrhosis, child puke, and pH scores. We also computed the Spearman correlation with the clinical parameters. For evaluation of the diagnostic performance of 40 flow parameters, we used binary logistic regression and ROC analysis for prediction of cirrhosis, pH, and clinically significant portal hypertension. The interobserver evaluation in 15 patients showed substantial overall agreement between observers in segmenting all vessels with a significant Cohen's kappa of 0.7. Area, velocity, and flow measurements showed acceptable interobserver agreement with coefficient of variation under 21% and Blunt-Alman bias under 5%. Test results in 4 patients showed excellent repeatability in large vessels with CV under 15% and bias under 25%. However, we observed poor repeatability in small vessels with high coefficient of variation and bias. When comparing patients with and without cirrhosis, we observed significant elevation of the splenic vein area in patients with cirrhosis, as well as a significant increase in the right hepatic vein velocity in the patients with cirrhosis. The logistic regression showed splenic vein area to be a significant predictor of cirrhosis with a significant AUC of 0.87. Correlations of 40 flow parameters to the MEL score showed trends of negative association between the portal vein flow and MEL score, as well as the portal vein peak velocity and the superior mesenteric vein area. We observed modest negative association between the Child-Pugh score and the splenic artery peak velocity. On the other hand, we observed strong positive association between the Child-Pugh score and the middle hepatic vein flow. This latter finding is in agreement with echocardiography studies, which showed different flow patterns and hyperdynamic circulation in the middle hepatic vein in patients with severe cirrhosis. Flow parameters in several vessels showed modest correlations with the pH score. Thus, the SMV velocity, the splenic vein flow, the superior mesenteric vein peak velocity, and the infrarenal IVC peak velocity were moderately correlated with the pH score. When comparing patients by Child-Pugh and pH scores, we found a significant increase in the portal vein area of patients with Child-Pugh B compared with those with Child-Pugh A. However, there were increasing trends for portal vein area in patients with Child-Pugh C compared to A. In patients with no portal hypertension, we found an increased infrarenal IVC area. And in the supraciliac aorta, we found increased velocity in patients with clinically significant portal hypertension. The latter finding is in agreement with the literature, which shows hyperdynamic circulation in the supraciliac aorta. In summary, the interobserver reproducibility for vessel identification was comparable to reported values for the portal circulation with a conventional Cartesian 40 flow acquisition. Our study observed variable test-retest repeatability depending on the vessels. The portal vein area, velocity, and flow were significantly decreased or showed a decreasing trend with severity of liver disease, which is in accordance with findings in the literature. The increase in the area in the splenic vein with cirrhosis and positive correlation of splenic vein flow with pH score are in accordance with observations by other investigators. These increases in splenic vein area and flow may be due to changes in vascular geometry with cirrhosis and portal hypertension. Our study had some limitations. Firstly, half of the patients had liver biopsy, and where biopsy was absent, we used imaging findings to infer the presence of cirrhosis. The imaging pH score was also used as a surrogate for invasive HVPG measurements. Our sequence had moderate anterior-posterior spatial coverage and moderate spatial resolution in one breath hold. This did not allow us to identify small vessels such as the hepatic artery or the superior mesenteric artery on test-retest acquisitions. This can be remedied with higher acceleration factor or acquisition split over several breath holds for optimal coverage of small vessels. In conclusion, spiral 40 flow allows comprehensive assessment of abdominal vascular parameters in one breath hold. 40 flow parameters have the potential to reflect vascular changes due to cirrhosis and portal hypertension. Our future work will correlate the flow data with the degree of portal hypertension based on hepatic venous pressure gradient measurements. Thank you for listening.